Welcome. This is going to be the case competition. I think this is the semifinals. We're going to start with Preston Panicco. And so each presentation is 5 minutes, and we'll leave a couple minutes for comments after each case. Thanks.
Thank you. I want to thank everyone for putting this together and allowing us to come out and speak. I'm Dr. Preston Panicco. I'm a podiatry resident, third year at St. Vincent Charity Medical Center in downtown Cleveland, Ohio. And this was an interesting case that I came across on my internal medicine rotation as a first year. So HPI, this is a 69-year-old male with a left fifth digit wound that's been present for the past 6 weeks. This has resulted from shoe pressure. Patient has recently noticed swelling and drainage and was treated with oral antibiotics. He denies any constitutional symptoms. His past medical history is significant for type 2 diabetes, hypertension, hyperlipidemia, and chronic kidney disease, as well as mitral valve regurgitation. Denies any past surgical history. His meds are listed. He has no known allergies, and he's a former smoker. On physical exam, his pulses were biphasic to the right foot, with a monophasic DP and PT to the left with a non-Doppler perforating perineal. Patient's skin temperature is warm to cool with no focal increase or edema. His light touch was intact. And as you see in the picture, he had a full thickness wound to the left fifth digit with about a cc of purulence and mild malodor. Also had mild pain on palpation. His labs, his ESR is elevated. His A1C is significantly elevated at 12.1. So we got some x-rays. As you can appreciate, there's obliteration to the head of the proximal phalanx and complete obliteration of the middle phalanx of the left fifth digit. You can also appreciate some calcified vessels to the dorsal aspect of the foot on the lateral x-ray. We did obtain non-invasives. There's a decrease in segmental pressures as well as an ABI, or at the digits was 0.97 and 0.64. So we got vascular on board. They performed the angio. You can appreciate the stenosis in the AT. Following the angio, patient did have Payton vessels. We did swab the wound. It did come back as MRSA. So our plan was we wanted to do a left fifth digit amputation with 6 weeks of IV antibiotics. We wanted to resolve this bone infection prior to the patient having a mitral valve replacement. Here's the patient's 3-month status post-amputation. Everything went well, no complications. And about 7 to 10 days following the patient's CABG and mitral valve replacement, we got consulted again. Patient had 10 out of 10 sharp pain to his bilateral lower extremities. His past medical history, same as before. Now on physical exam, his DP and PP pulses were monophasic. His PT was non-Dopplerable and the CFT was absent to the digits. The skin temperature is warm to cold, proximal and distally. Neuro, his light touch and protective sensation were absent. As you can appreciate the picture on the right, patient did have modeling of the plantar skin as well as a serous blister to the dorsal lateral right foot, and his range of motion was absent to the distal digits. The muscle strength was severely diminished to the lower extremity compartments, secondary to severe pain. Here's some more pictures. You see the serous blister on the dorsal aspect of the foot as well as the modeling on the plantar skin. Patient also had necrosis to the digits, which was later amputated by a plastic surgeon. So we were following this patient closely, and his labs, his white blood cell count, elevated at 21.6. All of his inflammatory markers were severely elevated, and his H&H continued to drop to 6.7 and 27.7. Here's some differential diagnoses that we were trying to come up with to see what this patient had. Our plan with vascular, we wanted nitroglycerin patches, reverse Trendelenburg, warm blankets, and a vasodilator. Vascular wanted to do a bilateral transtibial amputation. So here's the patient following his bilateral BKA. So how did this event occur? So the patient was suffering from heparin induced thrombocytopenia. This is caused by a formation of abnormal antibodies that activate platelets. The immune system forms antibodies against heparin when bound to the protein, specifically platelet factor 4. Most common symptoms, enlargement of blood clot or development of new blood clot. There's some laboratory tests that I'll go into. And the treatment is the cessation of heparin, in addition to an alternative anticoagulant to suppress the thrombotic tendencies. As you guys probably know, there's two types of HIT. Type 1 is the non-immune disorder. It usually presents within the first 2 days, and the platelet count does normalize with continued use of heparin. What our patient had was a type 2 HIT. This is an immune-mediated disorder. It usually occurs 4 to 10 days post-exposure. And as we saw in this case, it can have limb and life-threatening thrombotic complications. The 4T score, it's a clinical test used to rule out or rule in the diagnosis of HIT. For our patient, he had a fall in platelet count greater than 50%. This happened about a week to 7 days after the commencement of treatment. Patient did have the skin necrosis, and it could have been a possible alternative cause. So this patient's score was 7, anywhere from 6 to 8. There's about a 50% chance that the patient does have heparin-induced thrombocytopenia. Again, here's the 2 lab tests. The ELISA test is the most commonly used test. It detects all circulating antibodies binding to heparin. However, it does have a high false positive rate. And another test that can be used, it's the serotonin release assay. This is the gold standard for the diagnosis of HIT. However, a couple negatives to this is it's high in cost, and it does take a while for the results to come back. So the platelets are washed with serum and heparin, the sample is tested, and if there's a high serotonin release, it does have a 95% chance that there is a patient has HIT. Thank you.
Any comments or questions? Anybody, any comments or questions?
What is your, moving forward, he had the mitral valve replaced and all of this is a very extreme case of this disease. What's your anticoagulant, antiplatelet strategy moving forward with this gentleman?
Well, I believe he was put on we stopped the heparin and he was put on the argatroban ban. However, I'd have to look into it more how long he was on that for, though.
So he's most likely transitioned from argatroban to Coumadin.
Yeah.
Stayed on that. You know, PF4 is, like you mentioned, falsely positive, specifically after a pump run with cabbage. You know, the rate of elevated PF4 is pretty high, so the serotonin release assay is super important to make sure you have the right.
Yeah, it was an interesting case for sure.
How soon between MVR to amputation? What was the time frame of that?
I'm sorry, say that again?
The time frame between mitral valve replacement?
It was about, I want to say, about 2 to 3 weeks. Thank you.
Thanks.
Thank you.
Good morning. My name is Dr. Payton. I'm also from St. Vincent Charity Medical Center. I'm a second-year podiatry resident, and I'm going to be presenting a case about a subcutaneous hematoma that presented at our hospital. So we had a 58-year-old male who presented to our emergency department complaining of progressive pain and swelling to his right leg after 4 days. He states that the symptoms started after he struck his leg on his vehicle while exiting. He didn't feel that he needed to immediately seek medical attention, but he did decide to come in after he noticed increased pain as well as swelling to that leg, and you can see that significant size change. So the patient has a past medical history of end-stage renal disease, COPD, hypertension, and he has a history of a AAA with repair in the past. The meds are listed below, no known drug allergies. He denies all social history, and his review of systems was largely unremarkable. On physical examination, he was neurovascularly intact. There was significant non-pitting edema appreciated to the right lower extremity. Without any focal increases in skin temperature, there were no clinical signs of infection. But that calf measurement on the right side was 51 centimeters as compared to the left side, which was only 37.5 centimeters. And he did have significant palpatory tenderness on the right as well. So as you can see, it's a pretty significant partial thickness wound appreciated to the posterolateral aspect of his right leg. There's an underlying firm mass that measured approximately 15 centimeters in diameter. There was some sanguineous drainage as well. And he had multiple serous fluid-filled blisters that were surrounding the area. There wasn't any erythema. The skin was very taut, and there was no underlying fluctuance. So he was vitally stable. His labs were largely pretty much normal for his past medical history. The only concerning thing for us was the hemoglobin. There was definitely a concern for blood loss at that time, as this is quite low. And because of our clinical suspicions, we basically just went straight to a CT scan. We didn't get any plain film radiographs. I know MRI is typically the gold standard for evaluating soft tissue masses, but the CT sometimes, especially in the case of hematoma, can give some different characterization of the mass, and that's what we were looking for. So you can see it's a fairly homogeneous mass on the, involving the anterior and lateral compartments of that right leg. You can see there's significant impingement on that skin as well as the underlying musculature, but fortunately there's no osseous involvement. Looks like there's enough tissue in between the bones and the mass that we are evaluating, so we weren't very concerned about that. However, there weren't any calcifications, lobulations, or septations in the mass itself either. This is just a sagittal slice just demonstrating how large this mass was, and again you can see how it's impinging on the surrounding structures. So at this time, after imaging and our clinical evaluation, we determined that he had a subcutaneous hematoma. We planned to admit the patient, take him to the OR fairly emergently for that hematoma evacuation. We also transfused 2 units of blood, and we started him prophylactically on IV Ansef just to prevent any infection from starting. So intraoperatively, we made a vertical incision over the mass. We drained approximately 800 cc's of coagulated blood. Fortunately, there weren't any actively bleeding vessels in the area, and again, there was no osseous involvement. The wound did not probe to bone, but there was a pretty significant soft tissue deficit. And as you can see, there's quite a bit of devitalization to the overlying skin, and there was also some subcutaneous necrosis of the fat. So we knew that we were going to have to take the patient back to the operating room. We decided to take him in a few days just to allow the soft tissues to demarcate further so that we can do a definitive debridement. So this is a patient just post-op day 1. You can see that devitalization to those overlying skin flaps. The wound base itself was fairly fibrogranular, but you can note that necrosis of the underlying subcutaneous fat as well. And we also obtained post-operative x-rays. Again, no osseous involvement, fortunately, but there is a very large soft tissue deficit to that lateral compartment, which becomes a challenge, especially in a patient with end-stage renal disease. There's all sorts of complications with his connective tissues and wound healing. So during the operative case, we did take pre and post lavage cultures. This is actually the result from the pre-lavage culture. He did grow out bacillus and coag-negative staph species, but fortunately the post-lavage cultures were completely clean. We decided to keep the patient on IV Ansef just prophylactically, even though there were no clinical signs of infection. Fortunately, I had the opportunity to co-author a chapter on perioperative management of renal patients, and I did find some interesting literature in regards to wound healing and incision healing in these types of patients, so I just wanted to include a little bit of information. Most of the literature is in regards to animal models, mostly rodents, and they do demonstrate that there is definitely delayed wound healing in the uremic state. There's disruption of the fibroblast proliferation as well as a delayed rate of granulation. There's also abnormal collagen production and overall a low rate of vascularization and cell proliferation in these patients. There's also human research that supports these findings in CKD patients, and there are definitely CKD specific factors that put them at higher risk for impaired wound healing, including a chronic inflammatory state. These patients often have malnutrition, electrolyte abnormalities as well, and then just with these abnormalities, they tend to have fluid retention, which can be challenging to close wounds. Another thing to note is that in these patients, they typically have a vascular compromise. Peripheral arterial disease is a common comorbidity. The literature states that there's vascular insufficiency that's 3 times more prevalent in renal patients, and the severity of PAD does worsen with the increasing severity of CKD. So this patient is end-stage renal. We were definitely concerned about his ability to provide blood flow to heal the wound. So the plan, like I mentioned before, we plan to return to the operating room for that definitive debridement. Also at that time, because there was such a large soft tissue deficit, we plan to employ negative pressure wound therapy. We are also working to optimize the patient's nutrition with supplementation, and we wanted to evaluate his blood flow, so we ordered some non-invasive vascular studies and ultimately consulted the vascular surgeon for an angiogram. So these are the results of his non-invasives. Fortunately, there weren't any large segmental drops between the levels. His ABIs were largely regular. Even his TBI was in a good range, and his waveforms are regular with preservation of the dicrotic notch. And the vascular did perform the angiogram, but he did have 3-vessel runoff. There were really no indications for intervention at that time. So this is the patient at 2 weeks postoperatively. He's had that negative pressure wound therapy ongoing. You can see the wound base is largely still fibrogranular, but there is some healthy bleeding noted, and it's starting to fill in slowly. This is the patient after 4 weeks of negative pressure wound therapy. Again, you can see the wound is starting to fill in better. It's more superficial than it was before, and it's definitely more granular in appearance. This is a patient after 2.5 months. Again, he's had this wound back for this entire period, and you can see now that this wound is looking just like how we want it to be. It's almost ready for grafting, very superficial, nice and red and granular. And this is him at 3 months. At this point, we decided that he's definitely ready for some sort of graft application for wound coverage. So at that time, we planned to apply a human skin allograft. We've had a lot of success with that product. So we took him for an excisional debridement and application of that graft. And then we definitely wanted to continue with very good compression therapy. He had a lot of issues with fluctuating edema in the lower extremities. So this is the patient after graft application. This is him at 4.5 months. You can see that the graft is incorporated fairly well. You can see a lot of surrounding epithelialization to that wound border, and the wound has decreased significantly in size. This is him after 5 months. He's undergone multiple applications of this skin allograft, but he's healing very nicely. This is at 5.5 months, 6 months, and this is just a progression from the very beginning, how far this patient has come. And this is him. He actually was healed completely at 8 months, but when he followed up with us at 10 months, this is what his limb looked like, and we were all very pleased with the result. And we were very happy that we were able to heal him. Thank you.
So nice follow-up on your patient. And my question is, how does that graft you use compare to the skin graft?
It's very similar in all of its properties. It is cryopreserved, but it does preserve a lot of the, it's basically the same thing as a split thickness skin graft.
The uptake is the same?
Yep, it's all of the phases are all the same.
I have one question. Initially, when you guys put the graft, there was a lot of soft tissue missing over there. So how did the graft work? Because my understanding is you need capillaries to fill it, right? So how did the skin tip was taken up?
The patient underwent negative pressure wound therapy for approximately 5 months prior to grafting. He was actually a little hypergranular before we actually applied the the graft coverage. So we felt at that time it was definitely superficial enough for the graft to be successful, and it was.
Thank you.
Okay, thank you.
All right, so my name is Nathan Lloyd, and I have nothing to disclose.
And my name is Bradley Osemwenge. I have nothing to disclose.
We're second-year medical students at Texas Tech. We've been doing research with Dr. Ansari, and we're going to present on a case of carotid artery stenting in a type 3 aortic arch. Dr. Argueta was our mentor in putting together this case. So this is our abstract. We'll just move past that. But before we go on to this, just wanted to preface this by saying that in our particular region, management of type 3 aortic arch can be challenging. In accessing the internal carotid via the type 3 aortic arch is often challenging for the interventionalists. So we'll be presenting on a novel method to facilitate that access.
So onto the case. So we have an 87-year-old female who presented with symptoms of a transient ischemic attack. She had a past medical history of hypertension and diabetes, And whenever she came in, upon further investigation, it was discovered that she had 50% stenosis in her right internal carotid artery and then 80% stenosis in her left internal carotid artery. She was turned down for carotid endarterectomy by the vascular surgeons, and so she was referred to the interventional cardiology team at Texas Tech for further treatment.
So the first thing that the interventionalist did in her workup was the carotid artery Doppler, and you can see the turbulent flow consistent with carotid artery stenosis. They then followed that up with an angiogram, and in the first part of the angiogram, you can appreciate the type 3 aortic arch, and here you can appreciate the lesion. Despite the complexity of her anatomy, it was decided, nevertheless, to proceed with carotid artery stenting. So a glide wire advantage, no torque, Judkin's right, 6 French, was used to engage the LICA, and the shuttle sheath was exchanged over it and into position in the left common carotid. In order to facilitate that particular entry of the shuttle sheath, prior to inserting the shuttle sheath, it was bent into shape using the bent shuttle sheath technique by Dr. Ansari. Using this dual temperature heating gun. And this is inside the patient, but that shows roughly the shape that the shuttle sheath was bent into prior to entry.
And so the MOMO device is usually used for these types of procedures, but because it was a type 3 aortic arch, we decided to go ahead and use the EmboShield nav filter. And so the EmboShield nav filter was advanced past the lesion for embolic protection, and this kind of shows the blood flow. You can see the occlusion as well as the filter being deployed. This is before intervention. The stent was then engaged and deployed as depicted here. You can see that the stent is being deployed and the shuttle sheath is kind of helping support this process. So stent deployment. And then this is an angiogram post deployment of the stent with the nav filter still in place and then the nav filter removed.
And here we have our before and after. You can appreciate the improved blood flow after the procedure. And this is an image showing or a video showing the same thing. And so our main take-home point here is even when surgeons or when operators are a little less experienced, they can still navigate this complex aortic arch anatomy in some select patients. Thank you for your time.
Any questions? Any comments?
It's a case, these complex arches are very well attacked radially sometimes, just because the way the anatomy is. So a right radial approach, is certainly doable. I actually like those in complex arches. I think it's nice the way you shape the catheter got up there and by their image. Sometimes you can just overcome all of that by just going radial. I agree. The MOMA tracks fairly well. You don't have to use a MOMA for all your carotids by any means. Most people don't, I would say. But it does track fairly well. You may have been able to get it up there.
So for all the carotids, I prefer more. I use more because it gives both proximal and distal protection. But the type 3 aortic arch, no matter what wire we select, it always gives us trouble in the end. And if we're stuck, we're stuck. Going to the radial is a good option, but in old, short ladies with the tortuous radial, it's also very troubling. So that's when we said, okay, we use this for our ASDs and PFO to do the same technique. Might as well try this for the carotid, and it works really well. So you use a heating gun, you put it in such a manner that it tracks so really well, and once the shuttle sheet is there, then the procedure becomes very simple to do. The support is just incredible.
That's a nice job.
Nice job.
Thank you.
Good job.
Right. Good morning, everyone. I'm Ahmad Younes. I'm one of the interventional cardiology fellows at University Hospitals in Cleveland. And today we'll be presenting a quick case of 65-year-old female who actually was referred to us for acute limb ischemia. So this lady, 65-year-old, she's known COPD, run-of-the-mill, Northeast Ohio, comorbidities, diabetic, hypertensive, dyslipidemic, peripheral vascular disease. She did have actually bilateral iliac stents placed in November 2017. She did okay for some period of time, then represented to an outside hospital with lower extremity pain, thought to be acute limb ischemia. So her vitals upon transfer, she was hemodynamically stable. Exam is pretty much negative. She does have 2+ femoral pulses, absent distally. Her home medications include aspirin, lisinopril, albuterol, and heparin and Plavix were actually initiated at the index hospitalization prior to transfer. She still smokes. She's 45-pack-year smoker, and labs are pretty much normal. So her outside hospital angiogram, this is what right before transfer. So pretty much left CFA axis. There's not much flow going up in the aorta. They did balloon angioplasty for both existing stents, and this is the end results they ended up with. There is better flow, but it's still unclear what's happening in the aorta there. And the differential at that point would have been a dissection. Did they dissect on the way up? Is the aorta? This is a dissection flap, or there's just thrombosis in her current stents. So on arrival, she gets an ABI study and monophasic waveforms at the ankles. ABI is 0.26, 0.31, and the TBIs are pretty much flat lines. And it doesn't really require a cardiologist to know that flat lines is a bad sign. So the plan on transfer, we entertained few options. Vascular surgery to do an aortic bifemoral bypass. Remember, this lady is on Plavix already. Thrombolytics, still unclear how's the chronicity of her thrombus have been there, or endovascular interventions. So prior to transfer, the patient was on heparin. She did okay for some period of time, then on heparin, then later decompensated. So she got transferred to us on heparin. We took her to the cath lab. That was a late cath lab activation, but bottom line, we go left femoral approach. This is the tracings that we got from the femoral sheath, and the pressure is close to 30. There's not much perfusion distally. But the angiogram, the first shot, and I think it played already, we don't see any flow upward. So at that point, we started going up with a woolly wire with some Navicross support. And the way the wire was interacting here, it was still unclear if it's interacting with the stent struts or with the luminal thrombus or just it's going behind the stent. But our aortogram just confirmed that we're luminal in here. So on both sides, bilateral, we performed extensive debulking using mechanical thrombectomy and using the Penumbra device. So it's an 8 French system that goes up with a separator, trying to mobilize the thrombus, hoping to aspirate somehow. And we did that on both sides. We had a little complication doing all these maneuvers. The separator actually got dislodged, and eventually able to retrieve it outside of the body with no difficulties. So balloon angioplasty first with 7.0 balloons, both sides kissing at nominal pressures. We did just understand the mechanism of failure of the stenting. We did perform some IVUS run. And this is in the aorta here. We see a good amount of thrombus and the stents pulling back down to the bifurcation. There's still thrombus in the stents themselves, but there is significant undersizing of the iliac stents in the proximal iliac compared to the native vessel size. And we thought that's probably what's the mechanism of failure. The reassuring portion of this is we know that we're luminal. We're inside the stent with our wires and catheters. So balloon angioplasty performed, kissing balloon, and this is the angiogram that we ended up with. We finally deployed the 8mm stents, creating a new carina, which we tried to avoid as much as possible. Given the amount of thrombus in the aorta and the pathology that is there, we did create a new carina, post-dilator with 7.0 balloons, and these are the final angiographic results, which looks pretty much different than the presenting one. And these are the pressure tracings from both arterial sheath and her groin. We see a good dichrotic notch, and this is comparable to her upper extremity blood pressure. So ABIs prior to discharge, it's up to 0.85, 0.95, good dichrotic notch, triphasic waveform. Even the PVRs goes straight up and goes back to the baseline. So her discharge medications and follow-ups, she got discharged on a good mix of heart failure medications for her comorbidities. Antithrombotic therapy, it was just conversations to come up with a good regimen for her. Eventually, she got discharged on aspirin, Plavix, and Coumadin for 1 month, discontinued the aspirin, continued Plavix for a full year, then switched back to the Coumadin aspirin afterwards. She was seen on the follow-up afterwards. The patient is doing great. She's very thankful for what was done for her. Thank you.
So very interesting case, you know, a question regarding why we chose Penumbra as compared to other devices.
So that's a very good one. I think we suspected at that point a heavy thrombus burden, and the Penumbra device is an 8 French system. We thought we're going to be needing this much aspiration just to get things out.
Yeah, no, the take-home points are actually great, and this is a big problem with iliac CTOs and iliac stenting, that they're undersized.
Yeah.
And this happens, and Penumbra is a great choice because other devices are not 8 French, and the scepter really helps in taking on whatever clot is there. The other thing you guys used was IVUS, which is very important because that's one of the main reasons why iliac stenting, and you have all these cases coming back that are undersized, because nobody applies IVUS to these lesions, and that's when you find out what the real size. It's a good case, really good case.
Thank you.
I agree. The use of IVUS there, I think, is a big teaching point to help clarify your pathology. That's really, really important.
Thank you.
Hi, I'm Adham M out of University Hospitals in Cleveland, and I'll be presenting this case. So I have no financial disclosures. This is about an 86-year-old woman. She came in with a history of coronary artery disease, hypertension, type 2 diabetes, atrial fibrillation, peripheral vascular disease, and she actually had a right BKA about 4 years prior at an outside hospital. On presentation, she had a non-healing wound in the back of her left Achilles, and she was also complaining of some new gangrene of the toes for the past few weeks. The medications she was on at the time of presentation was atorvastatin, metoprolol, lisinopril, and clonidine. Her vital signs were heart rate of 67, blood pressure 140/70, afebrile, and satting 1 Romaire. If you look at her med list, actually, you'll notice that she was not on aspirin, despite being a known vasculopath. So we fixed that. And a few subtle findings on exam. You have an Achilles wound that's clearly got some, it's clearly got some viable tissue underneath there. You can see some redness and some white underneath, but you can also see that the edges are starting to get a little bit necrosed compared to the toes, which are just clearly in much worse shape, and you know that they're going to have to go. So we came in, and this is what we found. We got access from the right side, went up and around. You have some diffuse mild disease in the iliacs and the femoral, and then when you come down into the SFA, the distal SFA, you start having some more moderate disease, and you actually been occluded at the proximal popliteal and with very minimal reconstitution afterwards. So when this is your patient, you have a couple options for your game plan. You can choose to fix the inflow only, the inflow and just the AT, or the inflow and the PT, or all the above. Obviously, with the angiosome theory, you want to try and optimize wound healing and optimize circulation. So you want to just go all the way around, so you can have good inflow and outflow. So the answer would obviously be to fix both the AT and the PT along with the inflow. So first thing we did was we crossed the SFA lesion pretty easily. Did some direct injection again, and showing what we kind of already suspected. There's basically no below the knee runoff. Moving on, so we focused on our first lesion, which was that distal SFA/popliteal occlusion. We dilated it with a 5-0 and then went on with a 6-0 drug-coated balloon, and we had a little bit of a dissection flap afterwards. So coming in, we decided to address that dissection flap with a Super stent. We got it into place, and we were able to deploy that without any trouble. So now moving on to part 2, which is moving along the AT now. So we're going in, wiring along the DP, and we're actually able to get around the pedal arch. But towards the end of it, once we're going a little bit retrograde through the PT, we're having a bit of trouble moving through. Part of it, just once you get around that arch, you lose a lot of the support. So we focused first on the lesion that we had, which was the AT. We dilated it with a 2.0 and then a 2.5, and then we dilated a bit of the DP as well with a 2.0 balloon. And now just sort of talking about this with this patient, again, this is a person who has a right BK already, and so we're trying to salvage the left limb. So I think as we talked earlier, we want to get both the inflow and the outflow. So we kind of turned our attention to the last lesion, which is the PT. And coming in here, we weren't really able to go retrograde again because of the difficulty getting support around the arch, so we came in anterograde from the PT, and here we are just, again, having a lot of trouble advancing the arch. There's a lot of calcification. So we decided to obtain direct access to the PT and stick the wire through there and try to just have anterograde and retrograde access meeting up. So this is just, again, as I was saying, we were meeting the retrograde and anterograde access. If you look at the middle slide, you'll see, kind of just it meets perfectly and boom, right there. So we then went ahead to dilate that with a 2.5 and then a 3.0 balloon, that without much dissection afterwards. And here we are showing good inflow and outflow all around the arch and up in 18 PT. So we were able to get a TBI of 0.89 in this patient. And then, like we said earlier, so those toes, they had to go. She did get a TMA. This is her wound healing well at 1 month. And as for the Achilles, we were able to get a skin graft on, and at 6 months, this is what it looked like, markedly improved. So, and at 6-month follow-up, you can see ABI is doing well, still preserved, and so it's a couple things to keep in mind with this patient. With as far as revascularization, we wanted to just follow the angiosome to optimize her outcome, to keep good inflow and outflow. And it's always important to emphasize the multidisciplinary approach. It didn't stop just with us at the cath lab, but we had to rely heavily on our wound specialists. Thank you.
So any questions or comments?
So you mentioned 4 different options that you were thinking about when you thought about how to target and how to approach this. I think it's very good that you addressed the outflow, what you call the outflow of the tibial disease, because the first option was just inflow, SFA. And I think it's very important to know that if you get the inflow and you have no outflow, it will fail when you leave the room.
Mm-hmm.
So I think it's good that you went on to your other options rather than stop there, because it would have just led to failure.
Thank you. Thank you.
Is there anybody else?
All right, we move on to the following.
Is Lou here?
Lou, there's one.
Mohammad? Mohammad? Yes. Perfect. You're up. You get to use Lou's time too.
Well, I should have made a longer presentation. Okay. All right, everybody. Thank you for having me here. I'm Mohammad. I'm also from University Hospitals in Cleveland. I'm going to present a very interesting case that we did today. A lot to learn for myself. So I don't have any financial relationships. I don't have any finances anyway. So this is a 72-year-old man who comes in with hypertension, history of recurrent lower extremity DVTs, and I'll show a timeline of his DVT history in another slide. On lifelong rivaroxaban with an admit recently to an outside hospital with severe anemia and a duodenal ulcer. His hemoglobin at that time was 5.8, a baseline of 13. He'd received blood transfusions, and then they had given him an IVC filter and discharged him off of any anticoagulation. Unfortunately, he came back to the same institution a month later with new bilateral lower extremity DVTs, and then he was transferred to us for further management. He's also had struggles with recurrent bleeding in the past on anticoagulation. Pretty insignificant past medical history otherwise. He doesn't have any family history of coagulopathy or any family history of VTE. Never smoker, no alcohol, no drugs, and pretty standard medication list. Xarelto, which is taken off, simvastatin, ACTZ, and amlodipine, and propranolol for a tremor. So he gets to us. Vitals look pretty normal, saturating 100% on room air. Physical exam, remarkable basically for pretty significant peripheral edema bilaterally up to the thighs. He got to us, and then he was started on an IV heparin drip. And we consulted vascular medicine, GI, and interventional cardiology when he got to us. Just a little history about his deep venous thrombosis. You can see that going all the way back to 2010, he had his first episode of a DVT with a lower extremity clot. And then going forward to 8 years from then, he was diagnosed with his new extensive bilateral DVTs. That was the initial presentation at the outside hospital. And then when he got to us from there, a duplex ultrasound showed a thrombosis of his IVC from the filter that he had recently gotten all the way down to the bilateral iliacs. So workup over the years. So this gentleman was being followed by his primary care for a long time, and there had been extensive workup to try to find a source of his coagulopathy, and pretty extensive workup was negative. So we didn't really know why he was so coagulopathic. So this gentleman comes to us. What would you do? So there is a couple options we have. We can leave it alone and just treat it with medical therapy, meaning anticoagulation, or you can intervene. And in terms of how do we intervene, there are several options. You can do a mechanical thrombectomy. One of the options is the Penumbra device that we talked about a little bit earlier in one of the earlier presentations. You can do pharmacologic thrombolysis with ECOS or localized TPA, balloon angioplasty, and so on. In this gentleman, medical therapy wasn't really an option because of his history of bleeding, and so we decided to go for the clot with the mechanical thrombectomy device. So we go in, initial right femoral RFV access, and you can see that there's extensive clot burden right around here, with basically no filling and no reflow into the IVC, and you see the filter here. There's a little collateral on the right side. We decided to go and try to pass the wire from the right femoral vein, and you can see that it's going up, but we couldn't really get up across the filter because the clot burden. We decided to change things and go in from the right IJ and try to pass the wire from above, and again, because of the extensive clot burden, we were unable to cross. So what we decided to do was go after it with the Penumbra device. And the benefits of the Penumbra is, as we talked about earlier, the large French system allows us to take out more clot. And this is the first, in the first video you see here, using the Penumbra device. This is the separator wire that we mentioned earlier as well. It helps us break off the clot to get more clot suctioned out. Unfortunately, we did this. So this is after the initial attempt with the Penumbra through the RFB. You can see that there's really not much difference. Penumbra through the, in the first one we did Penumbra through the IJ. After this initial attempt, you see that there's really not much change, still have extensive clot burden. Then we decided to go after, do another round of Penumbra through the right femoral vein. And you have to be careful here. It's a little sped up for illustrative purposes, but this is a pretty large French system. You have to be careful you don't damage the blood vessel because you don't really use a guide wire here. And after this initial Penumbra attempt, you can see that there's some change, but then again, not much. This is the clot we got out with the Penumbra, not much clot retrieved. These are 4x4s for perspective. So what we decided to do next was use the Ansari aspiration device. And the strategy here was that the Penumbra helped us create a track with the little clot that was removed to go after it with the next device. In the Ansari, this is a flow retriever system, and what it does is it's basically a manual syringe-based system. So it's a pretty large 22 French system as well, and you can see it working here. And what you do is, as I said, it's a syringe-based system as opposed to the Penumbra, which is more mechanical and automatic. You basically aspirate out as much clot as you can. And we had multiple passes. We did multiple passes through the RFV. And then we did another round of the Penumbra from the RFV, and then ended up finishing it off with a balloon venoplasty, a 10 by 40 millimeter balloon. And then you can see that our end result looks pretty good. So our goal here was to establish some sort of reflow into the IVC. If you remember, starting from the beginning, this is the before picture, there's really nothing going into the IVC. And then you can see after that you do have some flow across the filter and into the IVC. And this again is a picture of the clot that we got out. The one on the right side you see the clot retrieved from just the Penumbra device. On the left you see the clot retrieved after we used both Penumbra and Ansari devices. And for perspective, this whole thing is a 4x4 opened up, pretty significant amount compared to our first attempt. Follow-up, so the patient tolerated the procedure pretty well. There were no immediate post-procedural complications. Our plan for this gentleman was to discharge him on lifelong anticoagulation because we knew that he would still be prone to thrombosis even after all of this. He was started on Coumadin instead of the rivaroxaban just because it's easier to reverse if needed. At 1 and 2 month follow-ups, this was in April, so his last follow-up was just a few weeks ago. He's been doing well. Swelling has gone down. Functional status has improved a lot. He hasn't had any more episodes of bleeding. And we did do a follow-up ultrasound that did not show any acute DVT in that extremity, in the right lower extremity. So lessons learned, several lessons learned. I think the most important one is that this is, as is with many other things in cardiology, it's a multidisciplinary approach is very important because when he first got here, we had to have vascular medicine on board because of his extensive clot history, GI on board because of his bleeding from his duodenal ulcer, and interventional cardiology. And all of this was sort of done after a consultation and extensive discussion with everybody on board. So I think a multidisciplinary approach and speaking with all of our specialists is extremely important. And the other lesson I learned was that was the synergistic use of the two devices helped us get optimal results in this patient. Just a couple seconds on management options for IV thrombosis. We have several management options. Anticoagulation is obviously the mainstay, but it can be limited if patients have bleeding episodes. You can use systemic thrombolysis. Surgical thrombectomy is usually very invasive and is left for the sort of like the last option for patients with malignancy-associated thrombosis as a palliative measure. And then you have endovascular options and adjuvant angioplasty and stenting. That's all I got for you.
How much time did the procedure take?
I think it was about, because we first went in with the Penumbra expecting to get some good result, but and then we didn't get it, then you had to use the Ansari. About an hour, I would say, 90 minutes, 110 minutes or so.
And did you guys ever consider taking out the IVC filter?
So that is a plan for the future. Because he had so much work done in this one visit, we wanted to sort of, and we got some reflow to the IVC, we just wanted to see how he did and follow up. So the plan is to, in future follow-ups, to get the IVC filter out. And maybe also consider doing the left side, because he had left-sided thrombosis as well.
Coming from someone who does a lot of venous intervention, so a few things. Number one, that Ansari device you use, the flow treater designed for the pulmonary system.
Yeah.
It's 22 French. Ansari has a clot treater device that's designed to treat the IVC iliacs. It's basically a big cage that you drag and pull this clot out. You can't do it if there's a filter. The Venagrain, you have some flow through the IVC, but I bet if you IVUS it, your flow is near luminous. No, I mean, it's minimal. So 100% that's going to close. And which is okay, because you're going to let that patient convert to chronic, and then they're going to require IVC reconstruction. 100% that filter has to come out. Like the filter is the problem. It is the problem. It has to come out. So I suspect you'll follow this patient. They will have some recurrent swelling. They will close the IVC, and once it turns chronic, the filter will need to come out, followed by reconstruction. I think the treatment of choice for that patient, if they could have had it, which they couldn't because of the GI bleed, is catheterectomy thrombolysis.
Right.
It is not thrombectomy. You have to pulse spray that with lytics. And the best option, I think, is TNK. If you give that 5 to 10 milligrams of TNK, wait 5 minutes, and then aspirate, you would have cleaned it up very nicely. Not capable. She had this GI issue. But that's the treatment of choice. And when you can't, you do what you do. And it was a good job. But without the ability to lyse and pull the filter,
So really, thank you, really limited in terms of what we could do. And as you said, the IVC filter has to come out, and that is a plan for us in the future.
Well, and these are long cases and important cases,
I
people
suspect
say
it was
that.
longer than an hour.
Yes,
That was like 3 hours.
If Matthew does it
More
in
than
1
that.
hour, it's going to be a big thing. These cases take us a long time. So,
And since Maddie was involved, it was clearly 3 hours.
exactly. It's not going to be 1 hour.
The other thing, all those clots the patient had up front, were they all left leg?
No, so they were bilateral in some cases.
Before the filter was put in, were they bilateral?
So if you go back and look,
Did you actually have pictures of what that filter got put in? Did they do a venogram? Did you look at the venogram when that filter
it
got
was
put in?
unfortunately the outside place, and we didn't have access to that.
Because I see just lower
It should have
extremity,
been
lower
hard to
extremity.
get through the filter. There was definitely a chronic
Which is-
component of that.
They want to
clear
come
on
out as
the
we have 2 days
right,
and
yeah.
And the clot they pulled out, though, you know, it was all dark, looked
Yes.
fairly acute. I think it would have responded to lysis, even if it was 2, 3 weeks old, it would have responded. But anyway, you know, a CT is important, I think, in this situation. You may want to make sure that guy doesn't have a left iliac problem that then led to DVT, that then led to filter, that then
Yeah.
thrombosis and is now.
Actually, very interesting because May Turner is actually 1 in 4 to 1 in 3 and a very underdiagnosed.
Correct.
actually.
And you can get right-sided Maythorn, you certainly can, but the guy's had extensive workup,
Right.
and everything's been negative. A CT would be reasonable.
Interesting, very interesting.
IVUS would be reasonable.
More-
You were there.
More better.
All right, well, thank you very much.
Aaron? Okay, you're up.
Figure out how to get this
Uh,
thing
just
back.
Keep forwarding.
Keep forward.
I think if you forward, it goes to the other.
Okay, cool. All right, gang. My name's Aaron Ali Sheikh. I am also from University Hospitals Cleveland Medical Center, Case Western, and I'm here to present this case we have here. So we'll go right to it. First off, I have no disclosures, as the previous slide showed. So, case here, we had a 60-year-old man, past medical history significant for metastatic prostate cancer to the bone. He underwent 4 cycles of chemotherapy. Then he presented with 8 weeks of worsening left lower extremity edema, erythema, and pain. They initially managed it with several different courses of antibiotics, thinking that it was cellulitis, but he had no improvement. Family history significant for lung cancer in his mother. Social history, he lived with his wife, who was a nurse, who was his primary caregiver. He had a 40-pack year smoking history. Currently, he was smoking about less than a pack. Denied any alcohol, illicit drug use. His medications were aspirin, Crestor, Lopresti, and Lasix, as you see here. On presentation, he came in, his heart rate was 69, blood pressure 122/64, respiratory rate 13, standing well in room air. Cardiovascular exam, neck, no JVD, no carotid bruise, regular rate and rhythm, no murmurs, rubs, or gallops. The extremities, the left lower extremity was diffusely erythematous. There was edema to the thigh. There was tense, hardened, indurated skin. Very tender to palpation, but his sensation was intact. And here is a picture of his of how he presented. You can see how that looks there, given the erythema and the edema. We got a CT abdomen and pelvis just to see what else is going on, given that he was not improving with the antibiotics. And this is going pretty fast, but you can see there's going to be a soft tissue mass coming up on the left side there. Sorry, you can't. But right here, and then there's proposed, they circled there a possible thrombus, and I have some stills here. So you see the mass here, there on the left, possible thrombus here, extending into the inferior epigastric, so just distal to the mass. And so they were thinking that maybe the thrombus was secondary to the soft tissue compression, that soft tissue mass. So they got a left lower extremity CT just to have a better characterization of it. And here it is, kind of zooming by here. I have some stills coming up, but I'll go and see. Then again, the mass and then the thrombus. Okay. So he was referred to cardiology for palliative therapy and also due to the venous compression and also possible thrombectomy. So they did a 5 French sheath here of the left iliac vein showing filling defects and some collaterals to the contralateral vein, as you can see over here. Okay, so talking about thrombectomy, I know it's a familiar slide. So we have a couple approaches: rheolytic, there's rotational suction, you can cannulate cannulating circuit, and then there's the ECOS for pharmacological. You can also do localized TPA infusion, and then you can go with a balloon angioplasty. In our case, we went with the Ansari flow retriever system that we talked about earlier, which is the 22 French system. You can see it being advanced on the right, or the left, sorry, and is this one moving here too? Okay, here we go. As you can see, there's still, the coil's still being compressed as it's kind of moving through here. likely due to the soft tissue mass. So the thought was, is this guy's presentation really, is it due to just straight compression, or was there really also some thrombosis in play here? So we moved on to, first off, they went and tried to do some thrombectomy, and this is what we were able to obtain. So we have minimal clot there, you see on the left, and there's still really, after thrombectomy, there's still really not great flow through the vein. Moving on. So we got IV ultrasound here. This is starting in the inferior vena cava, moving down, there's the bifurcation into the left iliac, and here is the compression of the mass, and here is the vessel being compressed. As we move down more distally, you're going to see there actually was going to be a chronic thrombus as we come down here in a second. Sort of, yeah, right here. So, given that there was minimal thrombus obtained, it was ascertained that we thought his symptoms were pretty much due to compression from the soft tissue mass. So, employed a compliant balloon here, and as you see, it was expanded to, it's fully expanded here. Yet, given that the balloon was fully expanded, there was still some ongoing compression you can see in this venogram here. So the decision was to go with a wall stent. 20 by 80 wall stent was deployed here. And after the stent was deployed, the patient had immediate improvement of symptoms, and he was referred for palliative radiation of the tumor. Okay, so given that the stent was deployed and we had improvement in the patient's symptoms, we had some lessons that were learned. One of them was that, similar to this May-Thurner's syndrome, compression from the soft tissue mass, in this case the tumor, can also cause venous congestion and DVTs. Our CT scan was deceiving. The slow flow that was seen on the CT did appear as a thrombic lesion, but despite aggressive mechanical thrombectomy, he still had ongoing occlusion from the extrinsic compression until the stent was placed. So the idea was, as the patient went through palliative radiation therapy and it would shrink the tumor, this stent that was not expanded to its full potential would continue to expand and allowing more flow through the vein. And also stressing the importance of using an oversized stent because it can prevent later migration of that stent. Thank you.
So you used IVUS,
Mm-hmm.
and as part of your case, did you use it at your completion?
Excuse me?
Did you use IVUS at completion?
I didn't see, no.
So that's a very important point, because what actually happens is, when you put the stent on, you have to use IVUS at the end of the completion, because that
Okay.
will tell you if you need to go in with the balloon again to overstretch the stent. Because the main issue with these stents are they can embolize. And they have been picked up even from the ventricles, the right ventricles. So this is
Okay.
it's very important point, is what she mentioned. Actually, I go in not only after the IVUS to balloon it, but I also try to flare the edges of the stent, just to make sure that the stent doesn't embolize.
Okay.
It's pretty common because people don't do that.
You also, just like May Thurner, if you don't hit the lesion and your stent is
Mhm.
not proximal distal to the lesion, if your stent lands on the lesion or the compression
Yeah.
point, then it will go down.
Okay.
So it's a missed target lesion, so
I agree.
you have to really look at the end. Even though it looks good on venogram is not a good study for the vein system.
And I would argue that this stent probably already closed. You know, it's a 20 stent, and in the end picture, it looks like it has an 8, lumen. You have to really aggressively pre-dilate these lesions, almost 1-to-1 to the stent you're going to put in. If I'm going to put in a 1690, I'm ballooning with a 16 atlas. I know there's a mass there, but they have to hurt. They
Mhm.
have to expand
Yeah,
really
they have
hard.
to.
And it has to be 1-to-1, and then you have to post-dilate these stents very aggressively.
Okay.
Because the pre-dilatation wasn't great, this stent will foreshorten if you post-dilate, and then with wall stent, you never know where you're gonna end up. I bet if you had IVUS, the lumen would have been pretty small, with a pretty high chance of going down.
Yeah, because if you put it in an 8, a 20, it
Mhm.
will lengthen. And
Correct.
unlike other self-expanding stents, your length is your length. It's
Sure.
not like it's gonna shrink and
Mhm.
then expand. So this stent is very different than the self-expanding stents we're used to in the peripheral system and the iliac system. So I'm not so sure that it's gonna happen over time as the tumor shrinks. I think you're gonna get an 8, that's what you're gonna get.
Okay, fair enough.
Good news is we have better stents coming, so I've deployed a few of the Aubrey stents that are down the road, and they're much better than the wall salons, so way more quick.
Thank you.
Thank you.
Thank you. So is there a missing person here or no? Okay.
I think it fell off this thing. Anyone left to present, because one person I think fell off the list.
I think that's it. All right, everyone.
What, Nicholas? Nicholas
Taylor.
here?
Not here.
Yeah.
And Badlamani.
Nicholas?
Yeah.
Yeah, you're up.
Perfect.
Running ahead.
Perfect.
Your colleagues are up.
All right. Thank you all for the opportunity to present. My name is Nick Mouawad. I'm a vascular surgeon up in Michigan. And I'm going to present an interesting case, Tale of Two Lesions, with a new device that I quite like. So the regular vascular patient, 67-year-old male, hypertension, has a rather remote history of tobacco use, Rutherford class 4 with rest pain, and a task C lesion. He's had no previous interventions, and his ankle brachial index is 0.18, so severe arterial insufficiency at rest. Here you can see the left superficial femoral artery. Clearly in the distal SFA there's a lesion, and even more distal at the level of the adductor hiatus there is a popliteal occlusion of CTO. A lot of collateral vessels. This is reconstitution at the P2 segment. And I'll show you the runoff, which is clearly the most important. Infragenicular vessels appear satisfactory. As you can see, the anterior tibial and PT fill quite nicely. Perineal reaches the ankle mortise without any concern. There is filling to the plantar vessels of the foot, as you can see over here, and there is a complete plantar arch. Interestingly, despite all that, patient has rest pain. I mean, a really, really low ABI for just a short segment chronic total occlusion of the distal pop. So there's two lesions here. Goal is clearly to manage them due to the critical ischemia and the Rutherford class 4. Approximately, like I said, in the SFA or the distal SFA, that high-grade stenosis in the CTO in the popliteal lesion. I elected to treat the proximal SFA with drug-coated balloon technology, and the chronic total occlusion of the pop started shifting more to using a scoring catheter called the Flex Dynamic Scoring Catheter. The popliteal lesion was around 5 millimeters. The length was 60 millimeters, as you saw. And for either treatment modality, I did not pre-dilate with a regular balloon. So just to talk to you about this Flex Scoring Catheter, it's a vessel prep device. What you plan on doing initially is to cross the lesion initially, and it's a pullback technique. It's 6 French modality, and you can use it either on 014 or an 018. I prefer the 018. I feel that you get more coaxial support in that regard. There's 2 treatment lengths again. A shaft length is 40 and 120. And the point is, in 3 different locations, 3 different angles, we have these atheratomes. It's a scoring sharp device to basically score the lesion, ultimately to prepare the device in which you can deliver the drug-coated balloon technology, the paclitaxel, whichever excipient you want to use, be it urea or polysorbitol. So these microincisions are controlled. They are at around 1 atmosphere and of a height of 0.01 inch. And again, they're at 3 different angles, so 30 degrees at each part of the lesion. So what you do is you cross the lesion, pull back, score the plaque, resheath the device, pass it back down again, turn it 20 degrees, 30 degrees, and this way you can have multiple different micro incisions. two quick studies here to discuss. This was a trial that was set up in Europe. 24 operators, 15 hospital systems, and basically the flex catheter is effective in recanalizing CTOs with very low levels of vessel dissection. And as you see, there was a luminal gain of over 30%. Very, very minimal provisional stent use for a bailout technique, and then there was the lesions were mostly or relatively calcified. Again, we use it as a vessel prep device, so almost everybody was receiving drug-coated balloon technology. Now, everybody loves the trials because they're all set up that way, but we also evaluated them in real-world data, over 83 operators, over 50 health systems, and again, you can see there's a satisfactory amount of luminal gain. We prepared the lesion for drug-coated balloon technology and flow-limiting dissections, embolies, and perforations, which are the worst thing that we don't want to see. We had 0%. Okay, so the flex is safe and effective in calcium, and it allows you to be able to deliver the drug-coated balloon or paclitaxel. Here you can see on the screen right that the device, in fact, is now in the below-knee popliteal artery in the P3 segment, and you unsheath the device, and then you do a pullback technique and take across the lesion that you want to treat. Technically speaking, at this point, you resheath it, you advance it, you turn it, and then you unsheath it and pull it back yet again. And you do that 3 or 4 different times. Ultimately, you exchange that again for your drug-coated balloon, and you can treat that. This is the flex technology without the use of any post-balloon. And so you can already see that you've had satisfactory luminal gain, and in fact, you've opened up the popliteal segment. Now, following that, if you use drug-coated balloon technology, or whatever balloon you want to use, I'm a very big fan of DCBs. You can see here you don't have to crank up the balloon to nominal pressure. I tend to not do that. My goal is to basically have satisfactory contouring of the vessel. I find that when you go up to nominal pressure, you tend to have more dissection. So, but in this case over here, we inflated it to good contouring, held it for 3 minutes as per the IFU for impact, and there was minimal, I don't know if you can see that again, I'm sorry, residual stenosis. No dissections, emboli, perforations that I've seen with flex or DCB. Most importantly, we'll discuss it a little later on, lower radiation, faster to do. The proximal SFA lesion, as you see, was treated with impact only. Okay, I do see a small little dissection, but it's non-flow limiting. And then the distal lesion in the POP with the P1, P2 segment there, you can see that no dissections or emboli, and you see nice filling of the infragenicular trifurcation. And then clearly you want to make sure that the tibials down the foot look okay, and you can take my word for it, but they do. And the perineal also fills, and then you can see the plantar arches again fill quite nicely and complete the arch in totality. So without vessel prep, as you saw in this kind of case control segment in the SFA, without pre-dilatation, did angioplasty, we did have a dissection that was non-flow limiting, just with the balloon angioplasty. With vessel prep, again, we were able to score the lesion. First of all, cross the CTO, score the lesion, get the luminal gain that we needed, and then ultimately assist in delivering the drug-coated balloon technology and let the paclitaxel do its work based on whichever excipient that you want. No dissections, no stents, which is what you want to avoid if at all possible. I found that it saves time, radiation exposure, very easy to use, 6 French platform. Thank you so much. Any questions?
So why not just use the flex catheter on a SFA lesion as well?
Oh, so absolutely you could. What we were doing, the reason why we didn't here was we wanted to basically show 2 different modalities in the same patient. That was really it. It was kind of our own case-controlled randomized trial. But otherwise, I would have absolutely done that.
Because you end up with a dissection there. And
Yeah, I completely agree. We wanted to show the difference. Hey, you know what? We prepared the vessel appropriately for delivery of the drug with a flex catheter at one point, and the other one without a flex catheter, and we found that you get more dissection. So the alternate discussion is now, so you know what? Why are you using a flex catheter? Why don't you use a scoring balloon? Well, so this was the whole particular reason. In the scoring balloon, you have a lot of the balloon effect that cause more dissection in order to kind of push through or break through the plaque with the scoring mechanism. Versus in this scenario, you just causing a micro dissection or micro incisions in order to deliver the drug into the intimal layer.
Any experience with this device in venous CTOs?
No. Well, I mean, I can't discuss it. No. But I think there'll be good application. Let's say even in dialysis segments, but for these purposes, no.
Thank you.
Thank you so much. I appreciate your time.